Thank you. This morning, I've chosen for my subject something that is very near and dear to the hearts of neonatologists and pediatric pulmonologists. And I've called it Bronchopulmonary Dysplasia, Myths of Management. And I'm asking the question, is there equipoise in the era of evidence? And I think this will become apparent as we go on. I have no disclosures or conflicts related to the content of the presentation. The two major areas that I will cover include the pulmonary injury sequence and pharmacotherapy myths that enshroud the management of BPD. And I'm going to start this with some observations that I have made about neonatologists over the 40 some odd years that I've been practicing. Number one, we are exceedingly slow to change. Number two, we are numericocentric, sometimes to the exclusion of clinical medicine. Third, we practice regression to the mean. And fourth, we like to think that we practice evidence-based medicine, but in reality, we don't. Bronchopulmonary dysplasia was first described more than 50 years ago by William Northway, who was not a pediatrician or a neonatologist, but was actually a pediatric radiologist. And Dr. Northway published a seminal paper in the New England Journal of Medicine reporting on 13 infants who had survived RDS, who weighed between 1,474 and 3,204 grams, and were between 30 and 39 weeks gestational age. Hardly the population that we deal with today in modern day neonatal intensive care. But what Dr. Northway did was try to correlate the radiographic findings with the clinical features of this group of patients. And from this, we derived the concept of the old BPD, which was seen in term or late preterm infants who had been exposed to high pressures and high oxygen concentrations. Their x-rays often showed overinflation, cystic emphysema, and fibrosis, and their histology showed interstitial and alveolar edema, small airway disease, extensive inflammation, and fibrosis. This is a typical stage 3 to 4 Northway BPD. I think you can all appreciate the significant hyperinflation of the lungs, the compression of the heart and mediastinal structures, and the so-called honeycomb appearance of the lung, looking at areas of alternating hyperinflation and atelectasis. And again, the histopathology is a photomicrograph from a non-survivor showing obliteration of the air spaces, lots of infiltration, and lots of debris. About 10 or 11 years ago, Alan Jobe thought that we ought to modify this and describe the new BPD. And this disorder was seen primarily in very low birth weight infants, many of whom had modest ventilator or oxygen needs. Their X-ray ranged from a diffuse haziness to a fine lacy pattern, and their histology showed decreased alveolarization, minimal small airway disease, and less inflammation and fibrosis than the old BPD. And again, I think you don't need to be a pathologist to appreciate that this photomicrograph is very different than the one I showed you just a few slides ago, showing the features of the new BPD marked by diminished alveolarization and much less inflammation than you saw on the previous slide. And when we put them side by side, I think, again, you can appreciate the significant differences between the old BPD seen on the left with the new BPD seen on the right. Now, I'm going to go through this fairly quickly. These days, you really can't show, or you really can't give a talk on BPD without showing something that indicates the pathogenesis of the disorder. And I'm going to start with a small tabular form of lung development. And as you all know, the lung goes through well-recognized developmental phases, beginning with the embryonic phase at 5 to 7 weeks of gestation and progressing through, again, well-defined stages until microvascular maturation, which occurs sometime between 1 and 3 years of age. Now, if we define the period of viable premature birth as between 23 and 37 weeks gestation, you'll note that the very youngest children born at 23 to 24 weeks may just still be in the canalicular stage of lung development, and they're just beginning to show evidence of septation and alveolarization. And this means that they are born with respiratory insufficiency. And because of inadequate lung function, they force us to initiate chronic ventilation. And when we superimpose chronic ventilation on top of the qualities of premature lungs, we find an increased susceptibility to an entity that we call ventilator-induced lung injury. And this includes surfactant deficiency, premature antioxidant systems, the premature lung structure, and something that we often forget in clinical practice, and that is that the chest wall is often more compliant than the lung, forcing us to compensate for this increased work of breathing. But there's also another pathway to injury, and the elements of this pathway include the direct effects of oxygen toxicity, lung and systemic infections, the battle that we wage every day in the NICU to provide adequate nutrition so these babies can grow new normal lung tissue, the effects of glucocorticoid treatment, both antenatal and postnatal. This is a good news, bad news situation I'll talk about in a few minutes. But we also need to remember that glucocorticoids are potent inhibitors of DNA synthesis and thus have a counter effect on lung growth. And finally, intrauterine cytokine exposure may be the linchpin for this whole thing that triggered preterm labor and is associated with fetal inflammatory response syndrome and its effects on lung development. And what happens with both of these, both the intrinsic and extrinsic pathways, is the end result of the inhibition of alveolarization and the development of chronic lung disease. So my take-home message here is that this is a very multifactorial disease, and that brings up two salient points. Number one, as intensivists, we don't like to sit still. We need to do something. And so it's not surprising that these babies are bombarded with multiple pharmaceuticals, many of which have a very poorly defined therapeutic index. And secondly, that the thought that any one treatment is going to ameliorate this sequence is really unrealistic. So let's explore some of the myths that I think I've uncovered here. And the first of these is that pharmacotherapy, including diuretics, bronchodilators, and postnatal corticosteroids, play an integral role in the management of babies with bronchopulmonary dysplasia. But the reality is there is an alarming lack of evidence to support the use of any pharmacologic agent in the routine management of infants with BPD, with the exception of vitamin A and perhaps caffeine, for which there is an increasing body of evidence. I love this quotation from one of the Rocky Balboa movies, in which an aging Rocky says, "The older I get, the more things I got to leave behind." And I think this is probably emblematic of many things, particularly the aging neonatologist who gains years of clinical experience. And on this slide, I've listed what I think is the life cycle of the neonatologist. Now, when we're young, we're in our 30s, we've just come out of training, we have a very high use of pharmaceutical agents. We're very eager to pull the trigger and to treat everything without a whole lot of clinical evaluation. And we're not very skeptical of what our mentors tell us. But as we gain experience and as we either lose hair or gain more gray hair, these two curves begin to go in opposite directions. And as we get older, I think we become more skeptical and we tend to use fewer pharmaceuticals. Now, my observation is I think these two lines cross somewhere around age 50, perhaps a little bit earlier for some and for others a little bit later. Now, let me try to bring this home with a real life example. I'm going to present the case of a 5-month-old former 25-week female who was transferred to my neonatal intensive care unit at 144 days of age. So roughly, again, 5 months. She had severe bronchopulmonary dysplasia with continued ventilator dependence, requiring 55% oxygen and fairly extensive ventilator settings. And even at 5 months of age, she weighed only 1.87 kilograms. This was the list of medications that she was receiving at the time of her transfer: hydrodiarrhea, aldactone, Lasix, sodium chloride, potassium chloride, Reglan, Prevacid, dexamethasone, Versed, Atrovent, and fluticasone. That is quite an extensive list of medications. And I might add that she had been on some form of corticosteroid therapy for all but 4 days of her life. We obtained a consult from one of our pediatric pulmonology colleagues who wrote this note in the medical record. And he said, given that she has cystic BPD, diuretics are an important part of her plan of care. The determination of whether to use Lasix or chlorothiazide and aldactone can be made based on her potassium level, given that fluid overload may further compromise her respiratory status. And when I read this note, it really struck a chord with me, and I really began to wonder, are diuretics really a typical plan, an important part of care? And so I started to go through the literature. And my thought was this note a really carefully thought out plan, or was it just a reflex based on years of observational practice and listening to what somebody's elders had once said? And so the first question I asked is, are diuretics an important part of BPD management? Now, there is a bit of historical perspective here in that infants with BPD do tend to tolerate excessive fluid intake poorly and tend to accumulate lung water. So water and salt intake must be limited to the minimum necessary to provide adequate calories in order to support metabolic needs and growth. But this has led to deductive reasoning, and that deductive reasoning says, so if I give diuretics, I can give more fluid and more calories and get the baby to grow better. But is there any science behind this? This was a wonderful systematic review done by Matt Lohan and Carl Bose, published about 12 years ago in Seminars. And they reviewed 2 Cochrane reviews that included small studies of single dose or short-term therapy and only reported short-term outcomes such as extubation rates, change in compliance, or the FiO2, but nothing long-term. And what they concluded is that the evidence does not support the preventative use of diuretics. Can diuretics prevent BPD? This was a very interesting study published not too many years ago, a retrospective cohort study. The babies included were born between 2004 and 2015, and there were 37,693 infants who were between 23 to 29 weeks gestation and 501 to 1,249 grams. And that's a pretty powerful statistical study size. And what the investigators did was to compare the exposure to furosemide or not between day 7 and 36 weeks post-menstrual age. And what they found was more than half of these babies received some degree of furosemide exposure. More likely, the more premature and the greater respiratory support you were requiring, and the more days of exposure was associated with the decreased risk of BPD. But there were some problems in this interpretation. Number one, it was a retrospective study and subject to a significant degree of selection bias because none of this was randomized. The two groups were not comparable, and the concomitant use of dexamethasone in the furosemide-exposed infants was statistically higher with a p-value of less than 0.001. And finally, day 7 may be too late. What about treating BPD? This was from an article by Tom Wiswell and Win Tin, published in Clinics in Neonatology in 2007, a little bit older, but they found that systematic reviews of diuretic therapy indicate some short-term improvement in pulmonary function, but this does not translate to any substantial reduction in ventilator support or duration. And they found no long-term benefits expressed as mortality, the duration of positive pressure ventilation or oxygen use, or hospital length of stay. Now, let's look at the physiology of diuretic therapy. What you see here on this slide is the picture of a Russian borzoi, a very nice dog. And what he's doing here is he's chasing his tail. He will go in circles forever, not quite being able to grasp the object of his interest. Now, when we as clinicians make a decision to start a baby on diuretics for bronchopulmonary dysplasia, whether it's treatment or prevention, we see some interesting effects. Number one, diuretics cause a diuresis. So the baby loses salt and water. And this makes the nurses very happy because a peeing baby is a happy baby. But the salt and water loss is not without its downsides. Over time, the baby will lose sodium, potassium, and chloride, will develop a contraction alkalosis, and will displace calcium from bones into the urine. But we neonatologists are very clever individuals, and we know how to take care of this. We replete the baby. We give the baby back the salt and the fluids. And what happens? The baby retains fluid. So what do? We give more diuretic. And so we get caught in this vicious cycle of treatment that ends up with the dog chasing its tail. I think this was brought home very nicely in a survey that was published by Jonathan Slaughter in 2013. This was a nationwide survey of neonatologists looking at the use of diuretic therapy for infants with bronchopulmonary dysplasia. And not surprisingly, what this group found was incredible variability from one unit to the next, with really no specific pattern of use. And I think that when we see this much variation in clinical practice, it just tells us we have no idea what we are doing. What about bronchodilators? Commonly used agents, but the evidence of their efficacy or safety to treat BPD is lacking, and yet their use is commonplace. And there is a paucity of evidence about the benefits and toxicity of chronically administered common bronchodilators. This is the same group. John Slaughter from Nationwide Children's Hospital did a second survey, and he asked about the use of inhaled bronchodilators for infants with bronchopulmonary dysplasia. And again, not surprisingly, there was a tremendous variability in use, but there was one pattern that evolved, and that is the longer you were on mechanical ventilation, the more likely you were to be treated with inhaled bronchodilator therapy. And so I ask, are these merely drugs of desperation? That the longer you stay on the ventilator, the more frustrated your neonatologist becomes, and he's more likely to try anything. Now, postnatal steroids, I'm not going to spend a great deal of time on this because I don't believe we've really found the answer yet. Large and small trials of postnatal steroids have claimed great attention and utilized enormous resources to try to address this question. And I think, going back to my movie theme again, I think my conclusion about postnatal steroids is they're good, they're bad, and they're also ugly. The good news is that we often see immediate beneficial short-term effects, which include a reduced oxygen need, weaning of ventilatory support, and in many cases, earlier extubation. The bad news is there are clearly adverse short-term effects, and these include hypertension, hyperglycemia, osteopenia, and immunosuppression. And the really ugly news is that there is an association with long-term morbidities, including adverse neurologic outcomes and cerebral palsy. And again, remember I said association, not necessarily cause and effect. Some of this may be related to timing. Early administration, defined as days 1 to 4, may facilitate extubation, reduce the risk of BPD, but is associated with gastrointestinal bleeding and perforation and adverse neurodevelopmental outcomes, including cerebral palsy. Later administration, defined as days 7 to 14, may reduce death or BPD at 28 days and 36 weeks without documented effect on the neurologic outcomes, but long-term follow-up data are very limited, raising caution. And finally, delayed administration, defined as after 3 weeks postnatal age, does reduce death or BPD at 36 weeks, and the trend toward more CP is offset by fewer pulmonary deaths and reduced mortality overall. But the combined outcome of death or CP did not differ. The increasing BPD trend coincides temporarily with the marked reduction in postnatal steroid use since 1998, when the Committee on Fetus and Newborn of the American Academy of Pediatrics issued its warning about postnatal steroids. So it's unknown whether this trend towards more BPD is related to the reduction in postnatal steroid use or the continued trend of the neonatal population towards more premature and more extremely low birth weight babies. I think still it's prudent to reserve the use of steroids to ventilator-dependent infants and to minimize the dose and duration of treatment. In a way, I think steroids are very addictive. They're not necessarily addictive to the babies, but they're highly addictive to the caretakers. A baby who responds to steroids is likely to get not one, but multiple courses. Each time the baby is stressed, somebody will say, well, he was treated with steroids, we better cover him with a stress dose. And before you know it, you have a baby like the one I presented, who is on chronic therapy for a very prolonged period of time. Having said that, I think the jury is still out. I don't think that we've done a good job of defining the appropriate clinical situations. And as an example, I'm sure many of you have heard or read about the DART trial that was done by Lex Doyle in Australia. And frequently on rounds, I hear residents or fellows quote the DART trial as the reason they started the baby on corticosteroid therapy. And when I question them and ask them whether they know that the DART trial was never completed, I get a blank stare and usually a one-word response, really? The other area that I'd like to cover briefly is reflux. And is it really a disease, or does spit happen? In our population, most reflux is not acid reflux, And therefore, if so, could the treatments actually be worse than the disease? I have a couple of adult studies that I put in here just as kind of a food for thought exercise. These three studies looked at acid suppression and calcium metabolism. We know that gastric acid facilitates the release of ionized calcium from salts. Hypochlorhydria may decrease calcium absorption. And these three studies showed that elderly adults who take proton pump inhibitors have significantly higher rates of hip fractures. Again, maybe not cause and effect, but clearly an association. This was another really interesting study that came out of Boston between the years of 2004 and 2007 that encompassed nearly 64,000 patients. And they demonstrated a 30% increased odds of hospital-acquired pneumonia in patients who were treated with antacids. What about gastric acid inhibitors and infection? Well, here's a pediatric study. This was a secondary analysis of prospectively collected data from a multi-center randomized controlled trial of bovine lactoferrin with or without probiotics to prevent late onset sepsis. And what the investigators found was that exposure to gastric acid inhibitors is independently associated with a prolonged length of hospital stay, and that this effect was time dependent. This was a neonatal network study done, as you see, published by Ronnie Gillette in 2006. It was a case control study of Bell's stage 2 or more NEC, necrotizing enterocolitis. Looked at 11,000 infants between birth weights of 401 and 1,500 grams. 7.1% of these babies developed necrotizing enterocolitis, and if the baby had received an H2 blocker, it increased the incidence of NEC by a highly significant p-value of less than 0.001. This was an interesting study by Ornstein, who is one of the gurus of gastroesophageal reflux in the newborn and young infant. And it was a trial of proton pump inhibitors versus placebo in 44 infants. Small study, but what they found was no differences in improvement after 7 days of treatment, and that there were significantly more serious adverse events with proton pump inhibitors with a p-value that was statistically significant, even though it was a small trial. This was a very interesting study that was presented at PAS. I'm not sure whether it's been published yet in a peer-reviewed journal, but this group reported on a retrospective cohort study of, yes, 874,447 infants. And these are infants who were treated with antacids before 1 year of age. They excluded infants in the NICU for longer than 7 days, those who had non-accidental trauma or osteogenesis imperfecta. And what they found was that PPIs resulted in a 22% increase of fracture risk, and the combination of PPIs and H2 blockers showed a 31% increase in fracture risk, and the highest risk was for those who were treated at less than 6 months of age. This was an Omari study in 2007 looking at omeprazole in preterm infants. It was a crossover design involving 10 patients. Again, a small trial, but it did show us some significant information. Compared to placebo, the percent of time with a pH less than 4 was significantly lower with treatment, not surprising. But there were no differences in vomiting, apnea, choking, or behavioral problems, which were the reasons that got the babies into the study in the first place. What about PPIs and kidney disease? Well, here's a recent study in adults that demonstrated a 20% incidence of chronic renal injury. And what was frightening about this particular study was that there was no forewarning by acute renal dysfunction. H2 blockers had a lower incidence, but were less effective in controlling the symptoms. And we also need to be concerned about drug interactions. We all know how many drugs these babies in neonatal intensive care get exposed to. Here's one that showed the combination of lansoprazole and ceftriaxone associated with a prolonged QT interval, a 40% increase in that risk. So in conclusion, ladies and gentlemen, the data underscore the importance of avoiding drugs without efficacy. Most infants exhibiting feeding-associated events do not respond to PPIs. And Orenstein has said, are empiric trials even ethically warranted? So in the era of evidence-based medicine, can we stop the runaway PPI express? This was a study that looked at the use of antacids and later allergy, a cohort study of nearly 800,000 patients. These babies are enrolled between day 35 and were followed to at least 1 year of age. It excluded if the initial birth stay was greater than 7 days or if allergy was diagnosed in the first 6 months. Exposure was defined as any dispensed medication for H2 receptor antagonism, PPIs, or an antibiotic, and the main outcome was allergic disease. They found that nearly 8% were exposed, and they followed these children to a median age of 4.6 years. And they looked at the adjusted hazard ratios for food allergy was 2.18 for an H2 receptor agonist, 2.59 for PPIs. And there were associations for other outcomes demonstrated, but weren't quite as strong. So in conclusion, then, there is insufficient evidence to justify the use of pharmacologic agents to treat gastroesophageal reflux in the newborn. Let me return in conclusion then to the patient that I presented a number of slides ago. I showed you the list of medications that she was receiving on her admission, and this was her problem list: nephrolithiasis, nephrocalcinosis, severe osteopenia, multiple pathologic fractures, hyponatremia, hypokalemia, hypochloremia, hypertrophic cardiomyopathy, and both systemic and pulmonary hypertension. Do you think any of these could have been attributed to that medication list she was on? Maybe all of them. In summary, then, current neonatal practices related to the management of infants with BPD are shrouded in myths. Commonly used therapies are not supported by the evidence. Remember that BPD is a multifactorial disease, and there is no silver bullet. My final thought that I'd like to leave with you, again, comes from Hollywood. Some of you may remember this James Bond movie. It was called Never Say Never Again. Why I've chosen to show this slide is the very first time that I gave this lecture, somebody questioned me afterwards and said, "Are you telling us that you never give diuretics, bronchodilators, steroids, or other medications to these babies?" And my answer was, no, I didn't say never, because if you remember the introductory slide, it said in the routine management of infants with BPD. So if you make a decision to start a pharmaceutical agent on a baby with BPD, number one, define your therapeutic goal. You don't put a baby on diuretics to increase urine output. You put babies on diuretics to achieve some measurable improvement in pulmonary function. Secondly, define a duration of therapy. How long are you going to continue treatment if you don't see an improvement in the child's status? Third, define toxicity. How long are you going to continue treatment if the baby starts to show adverse reactions? Fourth, determine the risk-benefit ratio, and therefore, fifth, discontinue the drug if it doesn't work. In summary, then, improvements in survival free of major morbidity are going to require a number of elements. Number one, cooperation among centers to perform good, randomized, controlled clinical trials. Funding and participation in well-designed multi-center clinical trials, and an educational commitment to the principles of evidence-based practice. And finally, importantly, maintenance of equipoise as new treatments evolve until the evidence either dictates their acceptance or their rejection. Don't just jump on the bandwagon. It's time for us to change our approach to infants with BPD. We need to move from eminence-based to evidence-based practice. Our patients deserve no less. And remember that their fate is in our hands. What we do in those first days and weeks of life may determine whether the baby goes home in room air or requires a tracheotomy, high concentrations of oxygen, and chronic mechanical ventilation. And remember that we all took an oath when we got our medical degrees: primum non nocere, first, do no harm. Thank you for your attention.